Thank you. So, uh, this was a nice analysis which came in JAMA Oncology. And this analysis looked at when the extended dosing of pembrolizumab was approved by the FDA. That is, you don't give 200 mg every 3 weekly, but you give 400 mg every 6 weekly. How this impacted the practice in US, and how many people adopted the practice and how many continued this practice. And to this, and what was that any difference in outcomes between patient who received 200 mg 3 weekly versus 400 mg 6 weekly. So the objective here was clear. They wanted to see how many adopted the external dosing strategy, and second, they wanted to compare the effectiveness of the extended dosing versus the standard dosing. This was a retrospective cohort. They looked at the Veterans Health Administration records for 1 year. Because it was the Veterans Health Administration records, predominantly these patients are going to be male. They excluded patients who received combinations of pembrolizumab with cytotoxic chemotherapy or patients who received TKI. So we are looking exclusively at a retrospective cohort of patients who received single agent pembrolizumab. Now what they have measured is actually from the prescription records with these veterans had from the insurance. And they also tried to see how many of them discontinued the treatment and how many of them, what were the outcomes of these patients. Now what you see here is after April 2020, you see that the steady increase in uptake of extended interval dosing. But what you see is that actually flattens out after December 2020. So once the COVID goes off, it has actually flattened out and not more than 30% of the patients are on the extended dosing. Now this is another thing. So let's say that the patient was on standard dosing and this approval came. How many shifted it to the extended dosing? And you could see here that around 40% of the patients who were on standard dosing were actually shifted to the extended dosing. The graph now, graph D, is actually for those patients who were on extended dosing, how many were shifted to standard dosing, and you could see that the patients who were on extended dosing, more or less 95% of them continued on external dosing. So what you interpret from these three graphs is around 30% of the physicians changed their practice to see that around 30%, I won't say 30% of the patients, 30% of physicians saw that around 30% of the patients were on extended dosing. Those who were on standard dosing, around 40% of them were shifted to external dosing, and those who were put on external dosing, they continued on external dosing. Now, was there a difference in the way this patient's characteristics were there? There was actually no much difference in this characteristic. It seems that patients who were having kidney cancer, there was a trend towards less use of extended interval dosing. Most of them were used for standard interval dosing. Rest all the things with respect to age, gender, primary site were actually, or whether it was lung cancer, non-cancer, it was matching. The key question is, this is a retrospective data, but it's a veterans health, it's like military record, so the data is quite of high quality. And you could see here that whether you extended interval dosing or you standard interval dosing, in all disease cohort, or with respect to the lung cancer and non-small cell, the outcomes remains the same. The idea why the authors wanted to do this was because extended dosing, according to them, would have led to an improvement in quality of life, less number of visits to the hospital, less number of time spent in the hospital, and that's why they wanted to say, or they were actually anticipating a lot more people would have taken up external dosing. So my take on this seems that we need to prime physicians, if the patients are affordable, that extended dosing can be used. It is FDA approved. It would lead to a less number of hospital visits. In this data, there was no data for comparison of adverse events, so that comparison we cannot do. But it does seem that the outcomes actually remains the same. And that's what they have said, that extended dosing, in spite of an FDA approval, still constitute only minority of patients, only about 1/3 of the patients. And in spite of that equivalence being shown, physicians at present still believe in the standard way of dosing. So my take with this seems to be a good method of administering pembrolizumab, where the patient has to come at a delayed intervals and would definitely decrease the number of hospital visits for the patients. Thank you.